Let's get 2 minutes on the clock and your time starts now. Dean Centre, a 28-year-old male presents to your GP urgent care clinic complaining of a fishing accident occurring 20 minutes prior. It seems during casting, a friend of his flicked the rod back, catching Dean's right thumb at the level of the interphalangeal joint. On examination, Dean appears comfortable. A photo of his injury is included below, showing a hook embedded into the interphalangeal joint of the right thumb. Question 3.1. What is aspects of investigation that might hint at a more serious injury? Provide 5 specific examination findings. Alright, time is up. Let's have a look at those answers. So, this is one of those cases that sometimes life throws you inspiration. This was something I saw the other day in general practice and I thought, you know what, probably make a good KFP question. So, of course, the key things we look at when we see these kinds of wounds is really about that neurovascular injury. So, evidence of vascular injury or decreased perfusion to the distal digit will get you a mark there. Evidence of a nerve injury / decreased sensation to distal digit will get you a mark. Of course, you wouldn't be phrasing it like that. You'd be specifying one or the other, or you risk overcoding. Evidence of tendon injury, or in this case, it's on the back of the thumb there, so you'd be saying inability to extend the thumb. Evidence of fracture / avulsion / bony tenderness, anything that's going to underlie bony or joint injury there. And, of course, obviously, contaminated wound. All things going to get you good marks. Coming in from the chat here, we have exit wound. I'm not sure if exit wound per se would hint at a more serious injury. Visibly dirty wounds certainly will though. Numbness at the fingertip, again, perfect. Looking at the nerve injury side of things. Visible first DRPJ penetration, yep, so again you're kind of getting into that joint involvement or bony involvement, and impaired first distal phalanx active extension, fantastic, again going into that tendon injury, well done. Also in from the chat, we have inability to flex interphalangeal joint, fantastic. Decreased temperature of distal phalanx, good. So that's picking up on the perfusion or vascular injury side of things. Decreased sensation in distal phalanx, fantastic. And too slow for the 2 minutes. That's right. We run out of time from time to time. I think you've hit a lot of nails on heads there. I think you've done very well. All right. So we've got this issue. What are we going to do about it? Let's put 2 minutes on the clock and your time starts now. Question 3.2. You assess there is no significant injury. Dean asked for assistance in removing the hook. Provide 5 management steps for hook removal. All right, time is up. Let's have a look at the answers. So, always think back to what are the individual step-by-step things you're going to be doing, as silly as you may feel at the time. So, of course, you're going to clean the site. You're going to be using a claw hex or appropriate skin preparation to clean the skin. Mark. You're going to anaesthetize the digit using local anaesthesia, and you can specify ring block. Perfect. Get your mark. You're going to remove the hook using a back out technique or advance and cut technique or a string yank technique. If you're not familiar with those, we'll go through in a second. Thought I'd take the opportunity to share, and that's going to be 2 marks there because it's actually addressing the issue of removing the hook. You're going to then irrigate the wound. If you have a potentially contaminated wound, irrigation is an important step to make sure that any potential foreign bodies can be irrigated and flushed out. You're then going to dress the wound with an appropriate wound dressing. You're going to repeat the physical assessment after the hook has been removed to see if any further injury has occurred during removal. And you're going to organise a wound review in 24 to 48 hours given the risk of infection in this space. Coming in from the chat here, we've got perform ring block, fantastic. Wash out wound, fantastic. Slowly remove the hook, fantastic. Use gauze to control bleeding and dress wound. You may get into overcoating there, or I'd probably diversify a little bit more between the use gauze to control bleeding and dress wound, but otherwise, excellent answers there. Prepare a sterile field, not on here, but yes, definitely, and would get your mark as well. Hand hygiene, again, yes, would get your mark. Wash off visible dirt, so again, cleaning the skin. Instill a ring block for thumb, fantastic. And remove nail with clean technique, remove hook with clean technique. Yes, I think you would probably get 1 mark if you're not specifying it as a technique for it. And you don't have to use these exact words. I think as long as you're describing kind of roughly what you're doing. But just saying you're removing it, probably worth less marks, sorry. So for those that don't know, the back out technique is literally as it sounds, following the path of the wound itself. Only good if you have a very superficial injury because you're going to traumatize the tract that the hook is in because you essentially have that barb cutting tissue along the way. Of course, we have some other options here. This is the push technique where you actually push the hook through the skin to actually get that barb back out again. You cut the hook so that you no longer have that barb there, and then you can very easily, very safely remove the hook back out from the original track there as well. I'm not as necessarily big a fan of this technique, particularly around joints, given the potential to actually cause more injury. But for, again, relatively superficial ones, can be a get out of jail card for you, particularly if you're not feeling as confident on using other techniques. Now, the string yank technique, and this is the technique I personally prefer, is actually using physics to your advantage. If you use, I normally use suture material or just some kind of string and actually tie that around the hook itself. As you can see kind of up on the screen, you can tie that to the loop section of it. And if you place pressure down on the eye, the kind of longer part of the hook, you actually angle that barb, you're pushing it down, so releasing it from the tissue, at which point a quick sharp yank on the hook will often bring it out of the tissue with minimal, if any, further trauma. Incredibly effective, works really well, relatively quick as well, which the patients often quite prefer. And I like that you're not then causing another hole, another potential source of infection to come in here. Okay, let's have a look at the chat here. So here we've got a comment. Old mate would have yanked that out himself 10 seconds after the accident in real life. You know what? Nah, not always. Particularly those people who are particularly needle phobic. And I've had patients that, or people who have seen the hook in and fainted and passed out, and ambulances have been called, they've been brought into ED, things like that. So a lot of fishermen probably won't be too concerned. This is one of those things, if you've been a fisherman for long enough, you've seen this undoubtedly. But yep, as happened to me the other day, people come to the GP for stuff like this all the time. These are little things I absolutely love. Excellent. Now, we still have one more question, so let's get to that one. Let's put 2 minutes on the clock, and your time starts now. Question 3.3. You ask about Dean's last tetanus vaccination. And he admits he can't recall receiving any. He asks if this is something he should worry about. You discuss tetanus-prone wounds. Provide 4 specific risk factors for tetanus-prone wounds. All right, time is up. Let's have a look at the answers here. And these are, of course, taken directly from the Australian Immunisation Handbook. And these are things we should know about when are we actually going to be giving a tetanus immunisation. Now, compound fractures. If you have a bone-breaking skin, that's going to put you at increased risk of tetanus infections, so you're going to give a tetanus booster if due. Bite wounds, any deep or penetrating wounds, any wounds that contain foreign bodies or foreign material, wounds that are complicated by pyogenic infections, wounds with extensive tissue damage, and that's example here is your contusions, so think motorbike abrasions or burns, and any superficial wound that is obviously contaminated. Any reimplantation of an evolved tooth also qualifies, and depot injections for people who inject drugs also require tetanus boosters. Having a look in the chat here, we've got animal bites, fantastic. Open fractures, fantastic. Wounds contaminated with soil, definitely. And penetrating wounds, I hear this hook. Well done. Coming in here, we've got a immunocompromised host. While that would increase the risk of the likelihood of you giving a tetanus booster, again, read the question being asked. Provide 4 specific risk factors for tetanus-prone wounds. I don't know if that would necessarily get you a mark. Potentially, but I would say I'd probably try and go by some of the other answers here. Visibly dirty, penetrating object, excellent. You've kind of covered 2 different things there, so I'd try and flesh those out to visibly dirty or contaminated and penetrating wound. Not up to date with vaccination. Again, going back to the question, risk factors for tetanus-prone wounds, probably wouldn't get a mark there, but you still picked up a couple of marks there, so I think you would still get through on that one.